Good morning, everyone, and welcome to CME Palooza Fall 2018. I am Scott Kober, one of the co-producers of CME Palooza, and I would like to welcome you to our Breakfast Gold session. This session is sponsored by ACHL, and the session is titled, here, let me call this up for everyone. Session is titled CME and MACRA, the Impact for Providers. Our moderator for today's session is Michelle Forcier. Michelle is the Senior Program Manager at ACHL. So before we get started, as we do with all of our sessions, I would like to recognize the sponsors of CME Palooza Fall. There are a lot of them, so bear with me here. We have our gold sponsors, ACHL and Genentech. Our silver sponsors, ASIM, Ethos CE Learning Management System, Forefront Collaborative, Integrity Continuing Education, Medscape Education, and Peer Audience. And our bronze sponsors, Answers in CME, Antidote Education Company, Catamount Medical Education, Clinical Care Options, CMEology, CME Outfitters, Creative Educational Concepts, Evolve Medical Education, Global Education Group, Helio.com Education Lab, Impact Education, Infograph Ed, Paradigm Medical Communications, Postgraduate Institute for Medicine, PrimeEd, Primary Care Network, Red Med Ed, RMEI, and finally, Vindigo Medical Education. So as with all of our CME Palooza Fall sessions, for those folks who are watching this session live, there are 3 ways that you can ask questions. This information is all included on the live page that you are hopefully watching this session on. You can click on the Google slide link that is found on the live page. The URL is here on this slide. You can use the CME Palooza text line to send in your question to 267-666-0CME. That's 0CME0263. Or you can tweet your question to us using the hashtag CME Palooza. All of those are ways that you'll be able to interact with our presenters for this session. So brief speaker disclosure slide. So just note that all opinions, discussions, and conclusions expressed by our panelists are their own and do not represent an endorsement or position of their employer, parent company, or affiliates. And with that, I am going to turn this over to Michelle to get us started.
Thank you much. Thank you so much, Scott, for hosting all of us and putting on the CME Palooza. We're really excited to get started. I want to introduce the speakers for our particular session on MACRA MIPS. We have my colleague, Amanda Kozgurski. She's the Senior Director of Educational Strategy and Design here at ACHL. We also have Tom Sullivan, the President at Rockpoint. And then we have Andy Rosenberg. He's a partner at Thorn Run Partners, and he's also a senior advisor to the CME Coalition. Want to thank you all for being here this morning. Hope everyone has their coffee. So let's dive right in. We'll dive right into the first slide. I'll kind of pass it along to Andy at this particular point, just sort of touching on the CME Coalition hot topics, DC happenings. Andy, I guess what's happening in the industry today? Can you touch on some of these points for our colleagues in the industry?
Sure. Good morning, and good morning, everybody. It's a pleasure to be with you. This past year in Washington has been interesting, to say the least, in a variety of ways, as everybody, I'm sure, can pay attention and see for themselves. But in the healthcare space, it's been particularly discombobulating, I guess is a good word, where you have sort of a strange set of cross currents where traditional Republicans and Democrats positions are sort of shifting. You see a major sort of potential for the meeting of the Trump world and liberal Democrats around issues related to drug pricing. And so this year in particular has been a particularly dangerous one for the pharmaceutical industry in that regard. And I think that next year, particularly if the Democrats win control of the House of Representatives, which is a very likely scenario, that you could have some real mischief being done between the Democrats and the Trump administration around drug pricing. Now, around drug pricing comes it sort of carries with it a cloud, if you will, of skepticism around anything that's related to pharmaceuticals, including, unfortunately, the provision of continuing medical education. And so we have to be very aware and cautious and vigilant about the potential for these political cross currents to catch CME in its wake. To that point, actually, one of the more interesting things as we look at this past year in Washington is there have been an unprecedented number of bills introduced around continuing medical education, and most of them actually on the positive side. In fact, no fewer than 14 bills were introduced this year. A lot of them around the opioid legislation. So the one big bill in healthcare that Democrats and Republicans were able to work together in concert over this year was a big opioid package that passed right before they broke for their electioneering and campaigning recess a couple of weeks ago. And as part of that process, there were a number of bills that were introduced by both Democrats and Republicans to mandate prescriber education around opioids. And ultimately, none of them got put into the final bill as passed. There was legislation that would require between 3 and 12 hours of prescriber education for doctors that prescribe opioids and deal with pain issues. Ultimately, most of those provisions were dropped, but it's very likely that we'll see an opioids 2 package next year that could pick up a lot of that baggage that was left at the side of the road. Democrats felt that the opioids bill that passed, although bipartisan, didn't put enough money or effort into addressing the epidemic. And so, especially if the Democrats take back the House, you're likely to see a lot more action in that space. There were some elements of the opioid bill that the final bill that passed into law that did impact CME. Some of the more positive elements were that there was a grant program for education on overdose prevention, in addition to the establishment and implementation of policies and procedures to treat and support recovery for individuals who have experienced a near fatal overdose. So some money and some direction was given to agencies to begin to develop programs around educating physicians, prescribers around the dangers and the limits of opioids. And so that's an area where we would expect to see maybe some expanded investment next year. And it's an area where the CME Coalition is going to be actively engaging and monitoring to make sure that if there are opportunities to be creating more activities in the opioid space, that our membership are aware of them, and that CME providers are developing activities and seeking and securing the funding that's made available through this bill. On the negative side, and negative meaning it doesn't really impact CME, but you'll all recall our friends, Senator Chuck Grassley and company, who have championed the Open Payments Program. The Physician Sunshine Act is the other name for it, that has created some heartburn around CME by requiring commercial supporters to report payments that they make to doctors, largely direct payments. CME is not really implicated in it because the definition has always has been worked out such that independent CME payments are not considered reportable. But nevertheless, CMS, the federal government, still requires that commercial supporters report when they provide medical texts or journal reprints to doctors. Well, that is still part of the law, but what the opioid bill did was provide a vehicle to actually expand the categories of providers that are now covered by open payments. So in addition to doctors and teaching hospitals and GPOs, which currently and previously had been covered by the open payments program, the new opioids legislation expands the categories of recipients that must be reported to include physician assistants, nurse practitioners, clinical nurse specialists, certified nurse anesthetists, and certified nurse midwives.
Okay. And I know we're going to discuss that as we continue the conversation. So let's get into the meat of our discussion here today. Just let's touch on, the basic overview of MACRA and MIPS at this point in time, and then the two different sorts of pathways that physicians can choose from. So Tom, if you can kind of give the audience just a basic overview of MACRA and MIPS, and then move into the two pathways. And I know there's going to be several questions too as we move along that I'll propose.
Sure. And Andy, why don't you just give them a background of how it was passed and the background of the bill itself?
Sure. Well, in 2015, Congress passed legislation that was largely geared towards ending the previous mechanism for reimbursing doctors under the Medicare program, and replacing that flawed methodology with something called the physician fee schedule. Instead, replacing that with this law, with MACRA, that creates a mechanism of reimbursement that incorporates both some elements of providing fee-for-service, but much more heavily with a bonus structure to drive physician participation in a quality in providing quality of care. So that, as Tom is about to explain how the MIPS program works, doctors now have an incentive not just to provide the basic care, but to sort of check the box, if you will, in providing standard of care that meets certain improvement activity and quality measure objectives. And in doing so, they can earn more money out of Medicare. And that's what Tom's about to talk about.
So thank you, Andy. So what happened was, when they created this program, it's now called the Quality Payment Program. And there's actually very good resources on the web. If you just type in Google Quality Payment Program, CMS has very good resources on what the Quality Payment Program is. So I encourage you to look at some of those resources as you're developing CME activities that meet the requirements of the Quality Payment Program. So basically, physicians, in order to be reimbursed, they decided, hey, we no longer want to deal with just giving you straight fee-for-service. We want to show that you're somehow improving quality. So they gave physicians two paths to be able to do this. One is what's called an alternative payment model, which is being part of an ACO or a comprehensive ESRD or some kind of bundled payment program. And then the other way in which they allowed this to happen was for the differential fee-for-service, or the MIPS program. And what we'll be spending our time is on the MIPS program. And then if you go to the next slide.
Actually, Tom, I want to just go back to that slide.
Okay.
Was just a couple questions tied to APMs.
Okay.
Some people may not be as familiar with the APM side. I know we focus a lot on the MIPS. So ultimately, APMs are exempt from MIPS. Is that correct? And
no, yeah. So APMs are, if you're part of an APM, you get a 5% bonus payment on your Medicare reimbursement. So if you charge $100, you would get $105. Okay. So it gives you an automatic 5% additional money to your payments from CMS. Now, there's only 5% of the physicians or the providers that are in alternative payment programs. So there are right now 700,000 providers, about 680,000 in the MIPS program. So if 5% of the total is about somewhere around 100,000 providers are part of an APM.
Okay.
And those are systems that have been set up mostly by health systems. Some large practice groups have set this up, but the APMs under the quality payment program have to be risk-based models, so that they have to take some downside risk. So there's a lot fewer of those than there are total ACOs, for instance, that are around, alternative care organizations, for instance, which are one of the alternative payment models. And so there's a lot fewer of those than there are other, that there's a lot of ACOs, but there's a lot fewer of them that qualify for the quality payment program.
And they can still participate in the QPP quality payment program. Is that correct?
That's part of the quality payment program. So it's like you have two paths you can go on. One
Right.
is differential fee for service, and one is an APM.
Right. Okay.
And sometimes if you, for instance, I looked at one of my doctor friends yesterday, and he's actually listed both in MIPS and in APM. So it gets very, very confusing for
Sure.
clinicians.
Okay, great. We'll go into the next slide.
So the next slide, this is just for reference for you. I'm not going to speak on it a long time, but basically, if you're in 2019, if you're an MD or DO or nurse practitioner, physician assistant, clinical nurse specialist, physician can go on the QPP website and just type in his MPI number, and it's pretty easy to look up your MPI number. Type in your MPI number and then your NPI number, and then you'll be able to tell whether or not you qualify. And again, about half the physicians qualify, half of them don't.
Sure. Just to go back to the qualifying physicians, they are expanding the definition of MIPS eligible participants. Is that correct in the upcoming years?
Yeah, so they're going to add nurse midwives, clinical social workers, clinical psychologists, dietitians, occupational therapists, physical therapists, speech pathologists. They're going to add all those into the system, and it's not clear if they're going to do it in 2019 or 20. It's probably 2020 when they add them in.
Okay.
So if you have for instance, you have a large physical therapy operation, and you have a lot of Medicare patients, this could absolutely cover you. Again, your threshold is 200 patients or 90K of billing. You have to have both in order to qualify. So if you have 300 patients, but you don't have 90K of billing, you don't have to report. Or if you have 90K of billing, but you don't have 200 patients in Medicare, then you don't have to report. It's only if you have both. Okay.
Okay.
So the breakdown in payments are quality. You have to qualify for 6 measures. There's about 450 potential measures that you have to basically report back to the government. At least one patient, but more preferably up to 60 or 70 patients. You report back to the government that these are the quality measures we measured on you. Typically, people in their EMR systems have this already built in, or they're working with a National Qualified Data Registry. So this is all kind of built into the sauce that's in the data registry, and they'll pick out your best quality measures that there are. The other piece is called cost, which is based on 20 cases. So they'll look at 20 plus cases, and they'll figure out, are you a high cost provider in your area, a low cost provider, and they'll give you a certain score based on your cost compared to others in your area. So if you're a high cost doctor, and let's say you do a lot of referrals, a lot of procedures, you're going to end up paying more. The other area is advancing care information, which has now been changed. Government likes to change models. In 2019, it's going to be changed to promoting interoperability. So they want physicians to do more interoperability or advancing or using their data. And part of the CME activity and what we're going to be talking about is teaching physicians how to use their data so that they can improve care. The other area which we're going to spend our time on today, which is improvement activities, and this is what's important to CME providers, is how do we create CME improvement activities so a physician can meet the standards of doing these improvement activities, and then get credit for actually doing CME programs.
Sure.
So
And
go on. Go ahead.
Sure. And I was just going to say, as we touch on the improvement activities, I think the next slide brings us to the penalties and the incentives year over year in time.
Sure. So as you can, and he doesn't have the slide up, but basically in 2019, which was the year in 2017, 2017's work was a 4% up or down payment. Next year in 2019, which is 2021 payments, so it's a little bit odd the way these things fall out, but you do the performance 1 year, it's called a performance year, and then 2 years later is how you get paid. So next year will be a 21%, a 7% change in your payments. You could either be -7 or +7 depending on how well you score. And then in 2022, it's 9% up, plus or minus. So let's say a practice or a physician, they bill $500,000 to Medicare. 9% of that is $50,000. So that's a huge, or 45,000. So it's a huge amount of money for physician practice over time. So. So it's and if you have a bunch of physicians, it can cost a facility quite a bit.
Sure. Okay.
So they're very motivated. So
sure, of course.
Yeah, they're very motivated. They're very motivated to meet these standards. Just to give you an idea, if you're a group of 15 or more, you have one set of standards that you have to meet for improvement activities. If you're from groups of 15 or fewer, you have less activities that you have to do, but you have to do improvement activities.
Sure.
And improvement activities can be being part of a clinical data registry. They can be doing MOC Part 4. It can be a CME activity that meets this standard. So it's a whole variety of pieces on that.
And going back to this slide with the weighted activities, I thought this was very interesting. Can you sort of talk to how a performance improvement is weighted, particularly weighted, tied to this slide?
Sure. So high weighted activities are things that they think you'll have to do for a longer period of time. Mm-hmm. So a high weighted activity can be, and it's things that the government sees as a higher priority. For instance, a high weighted activity would be being in a patient-centered medical home. It would be being participating in a data registry. That would be a high weighted activity. A low rated activity or medium weighted activity, no call them low, it's just medium weighted activity would be doing, again, a CME activity. It would be doing MOC Part 4. It would be doing a course from maybe participating in an IHI course. That would be considered a medium weight activity. In a high weight, another high weight activity, which is doing the CDC's opioid course, which is a 1 hour course. So it just really, it's kind of random, but they're trying to get more, you have to do more work in order to get a highly weighted activity for the most part.
Okay. So I think we'll go into the CMS, the proposed description. I think one question that I have, and I'm sure a lot of my colleagues have, is how did the industry band together to bring this ruling into fruition?
So we have a improvement activity and that has been approved by CMS for MACRA. And it's important that we as CME providers implement these activities. Mm-hmm. So how this came together was a couple years ago, several CME leaders kind of were discussing, how can we become relevant inside of MACRA? And we formed the CME MACRA working group. and which includes a lot of larger societies, the ACCME, the Alliance, the AMA was part of this, a whole variety of people. Andy, do you want to talk about it a little bit?
Sure, Tom. Well, it was just a process that we at the CME Coalition sort of initiated, pulling together the CMSS. We worked with the ACCME, and as Tom alluded to, quality is the direction that reimbursement is going, and we needed CME to be a part of it. And we're actually working on trying to get a second improvement activity around CME. This would be around FDA opioid REMS approved by CMS, and we're working on that as well. And we just want to the degree that we can, make sure that the folks at CMS that are creating the incentives for doctors under the Medicare program to appreciate the importance of aligning with CME and aligning with some of the requirements that doctors are already expected to meet in terms of their credentialing and the like, but they ought to be getting credit for it. And we also ought to be encouraging doctors to improve their practice and to better understand how to enhance patient care, and they ought to get credit for that under the MIPS program. And that's what we're working with this group of stakeholders, is to get the decision makers at CMS to better understand the potential of CME to achieve their goals.
Sure. Is there a formal approval process for an activity to be approved by CMS?
No.
In order to be an improvement activity, there is a formal process you have to go through. It has to be submitted as they have like a call for quality measures, so it's not clear what that is, but you have to submit into the call for quality measures, and then they have to review it, and then they come back and they decide. So it takes about 2 years.
But I want to make sure, is your question about whether or not an individual CME activity must go through a process of being approved, or that's what you were asking, right?
Yes.
Oh, okay.
Tom,
I'm sorry. Yeah. I'm sorry. I thought you meant like if you wanted to have like a new category of improvement activity.
Oh, well, both. I mean, those are both great questions. Sure. But in this case, an individual CME activity.
So if you have an individual CME activity, you don't have to get approval from anyone. It doesn't even have to be accredited, and we can go into detail on this. It just has to meet the criteria, and it has to be documented that it meets the criteria.
Okay.
Right.
So the criteria is that a accredited performance improvement continuing medical education program has to meet. There's 5 things it has to meet. 1, it must address a quality or safety gap that's supported by a needs assessment or problem analysis. It must support the completion of such a needs assessment as part of the activity. So part of the activity is for them to do a survey, some kind of a need, some kind of a need at the beginning. The activity must have a specific measurable aim for improvement. So you have to have something that you're trying to improve. So, and it doesn't have to be a quality measure that's under the MIPS program, or it doesn't have to be a necessarily quality measure. It can be improving hand washing at the hospital. It can include it can be improving diagnosis of a rare disease. I mean, there's a lot of things that it can include. The other is that activity must have interventions intended to result in improvement. So what are you going to do as part of the CME activity that will result in improvement? And what are the interventions that are going to happen along the way? So it's not just listening to a lecturer. It's what are we going to do in between the lecture and some of our follow-up that we would that would result in improvement. The activity must include data collection and analysis. So somehow you have to collect this data back from the physician. It can be, again, a survey and the impact to assess the impact of the intervention. Did he use, for instance, if you're using a diagnostic test or some kind of a patient discussion form or some kind of patient interaction form, is he actually using that? And it must define what does meaningful clinical participation mean. So they have to participate somehow meaningfully in this activity, not just, again, sitting and listening to what's happening to meet the requirements for this.
Sure. So, you know, if CME providers are, you know, working on bringing these improvement activities to life, I know with reporting to the ACCME, are they adding a specific bucket for reporting for these particular types of activities? Or is that in discussion?
Well, they've come up with a criteria, and Amanda is going to talk a little bit about that a little later. Mm-hmm. And they've come up with a criteria, and it's been added now to PARs if these activities qualify, so they can keep track of who's doing these improvement activities. So it's now part of PARs reporting.
Okay. Okay. So the next slide, Tom, if you want to speak on just the opportunity for CME and quality improvement, just the benefits tied to that. And then I think there's several questions that I have about physicians submitting this sort of data on their improvement activities.
Sure. So really, I think the opportunity is what's been missing from QI as far as credit is to have credit for learning how to do improvement, how to do quality improvement. There's been no real credit that anyone gets for learning how to do this as far as reimbursement credit. So this is for the first time we're now giving reimbursement credit for learning how to implement quality improvement. So that's a huge piece of this. And in a lot of respects, this supports the collection of data, i.e. we're encouraging by having this improvement activity, we're saying, hey, if you start to collect your data, you start looking at at what's the changes to your patients, you're starting to pay attention to what's happening in your practice, you will get reimbursement credit. It also helps as far as when it contributes to advancing care information credit or improving interoperability, you're teaching people, again, how to use their data. You're forcing them to say, hey, how do I look this up? How do I register this? Like there's not been a lot of teaching on how to do it. The government is really good about saying, you know, here, go figure it out, go do it. But not necessarily giving any credit for learning how to do it. The other interesting thing is you can combine this activity with other improvement activities. For instance, if you're entering data into a data registry as part of your CME activity, is to say, you know, working with your data registry, they can get credit for that, or working with their claims data, or and so basically at the end of the day, you can contribute. By doing this, you can contribute about 40% of their composite score, which is their improvement care information or their promoting interoperability credit, plus their improvement activities, all by doing one or two different things. In addition, you can also qualify for MOC Part 2 and Part 4 in these activities. So you're doing, because again, MOC Part 4, which is also an improvement activity, but MOC Part 4, so we give you the two improvement activities. And MOC Part 4 is something that physicians always have trouble trying to collect information on. It's always kind of done last minute. So if it can be part of an education activity, the more the better. Sure. One thing I would recommend if you're a hospital or a small practice is that you involve the local QI department. They probably have no idea that this improvement activity exists. And if the two of you work together, you can come up with a nice piece for your hospital.
Sure. And I want to go back to the data piece too of professionals submitting the data. How do they attest to completing a improvement activity? Is there a checkbox? Do they upload data? How do, you know, what data is needed to support that they did a performance improvement activity?
So an improve for the other areas of MACRA, there are submissions through claims data, through like for instance, if you're doing quality measures, there's submission through claims data, there's submission through PQ through quality, through data registries. There's all kinds of ways in which a physician can submit his data into CMS. For the improvement activities, it's a self-assessment test that's online, and they have to go on and do it. There's no other way to get around it. They have to go in order to show that you've done an improvement activity. They basically go through and they check boxes of which ones they've done that year. But they have to have. There are audits for. There are payment audits, and if you don't have that documentation that you did it, and then meeting the certain criteria, you're not going to.
Okay.
I see you back online. Are we having a problem?
We've got a question.
Oh, okay.
So I wanted to just kind of follows up with what Michelle was just asking. So here's the question. So is there any clarity from CMS around whether physicians need to submit actual patient data to a CME provider, or do they just attest to improvement to the provider?
They just have to attest to improvement to the provider. They don't have to give them. You don't want to get into the collecting patient information game, because that requires a whole lot of that's like opening up a Pandora's box that we as CME providers don't necessarily want to get into. You don't want to have an IRB, for instance, because if you go down collecting patient data, now you have to get into having to deal with an IRB. So that just opens up a whole can of like a Pandora's box that is a lot more complicated. We actually just went through this, so I can attest. This is not for the lighthearted, and for an improvement activity that we're working on. So just be prepared if you're doing this. Survey data is plenty good for and self-attestment from the physician that they check the records of so many patients, or they use this test on so many patients, or they use this survey form with so many patients, or they had this many patient encounters where they practice shared decision making. All that can be part of, and try to keep the amount as low as you can in order to guarantee participation. So I would say they have to do 90 days participation for all of these activities. So you have to show improvement over 90 days. So it could be a survey at 45 days and a survey at 90 days, so that you have some kind of, so he's thinking about what he's changed in his practice.
Okay,
okay. Oh, Scott, go ahead.
So we've got another question. I think Michelle sort of already asked this in a different way, but I'll ask it again, and and you can kind of chime in. So, are there any specific requirements about documentation that the CME provider needs to provide back to the physician that they can then use to back up their attestation to CMS?
So it's important that they have some kind of a certificate or some way of saying that you've participated in this. But that CME provider can have the backup documentation of how the participation happened. They can, and usually the physician keeps kind of records of what he's done. But you can give them back we have a worksheet that we'll talk about a little later. You can give him back all the data that's in that, and then he should be good to go.
Okay. I even heard records of phone calls would qualify too as backup as well. I thought that was interesting. So save, document and save.
Yes, documentation, just like CME, just like you guys are CME providers. Nobody has to do more documentation than a CME provider, right? You have you have acres and acres of papers you have to keep on every activity. Just consider this more acres, another half an acre of paper that you have to keep to just document that you've done it.
And Tom, when the sorry to interrupt, but when the provider is putting together a description of the activity, they could also, and they ought to also sort of parrot back some of the criteria that CMS is looking for, right? Saying this activity does the following things, 5 things.
That's correct.
Great. So I think we'll go into ACCME step-by-step guide, which kind of touches on how to identify which of your existing activities, your existing CME activities could qualify, and associate with improvement activities. So I know my colleague Amanda was going to run through some of these points on the guide.
Yeah, so it's on the PowerPoint slide that Scott has showing, but it might be hard to read. So I do suggest that anyone who's interested and should go to the ACCME's website. They have a section called CME for MIPS, and it's an extremely helpful section. There's a lot of resources. There's an FAQ, and in that section on the ACCME's page, there's also this step-by-step guide. And it's very helpful it has the criteria that Tom went through a few slides back about what CMS's expectations are. So that's what you'll see on the left, the A, B, C, and D. And then what's listed on the right are what some of your activities might already have in place. And it will show essentially if your current activities are meeting these CMS requirements for CMS improvement activity, or it can give you ideas for what other tactics or interventions to include in your activities to ensure that they will meet improvement activity qualifications. I think that the big thing that we're just starting to touch on now is that the improvement activities are a great way to essentially make a one-stop shop for your physicians and your providers, because as Tom had mentioned previously, they can earn MOC credit, they can earn their CME credits, they can earn their CMS MACRA improvement activity points. And a lot of physicians feel like it's a burden, but when it's bundled together like that for a physician, it can really kind of soften the blow of an improvement activity being, just another process I have to go through. Included in the step-by-step guide from the ACCME, there's also some suggestions for MOC requirements and which boards are collaborating with the ACCME. And it helps with how to report and guides for reporting. As Tom mentioned, the PARS system does have a box now where they can check, as a CME provider, you can check if it's a CMS improvement activity or if it qualifies for MIPS. So that's for our own reporting for the ACCME. Now, right now, the ACCME isn't reporting that information to CMS. It could be something that happens down the road, but right now, what we report to the ACCME for physicians who are participating in these activities that qualify as an improvement activity, that is staying right now with the ACCME.
Right.
Yeah, and CMS was pretty clear. They're not really wanting, they're very much, they have to collect data on 1.778 million providers. So they're only really interested in like things that they can get on an aggregate. So since there's so many different improvement activities, over 100 of them, they're just wanting people just to check the box. For them, it's easier for people just to go online, fill out a form and check the box. Sort of like doing your taxes.
Yeah, and some of the improvement activities that are listed. So Tom said that there's over 100 activities. Our CME quality improvement activity is of those 100. But if you are creating a robust QI activity, you might be able to also meet another improvement activity that's listed in the CMS activity listing. So there could be a few points that are earned for the improvement activity that clinicians are participating in.
So we've got another question that just came in on the text line. So I'm going to read it off my phone here, which I think is a pretty good question. So here's the question. Can you speak to the AMA versus CME requirements for PICME, it appears that there is a difference between designated when a project actually begins. Is it true that one allows for review of data and the other doesn't? And if this is the case, how do we assist physicians that may have come to us with a project idea around data they've already reviewed?
Well, I'll just address it a little bit, and Amanda, if you want to talk about the ACCME, but the bottom line with this is this is not a PI. You do not have to meet the criteria of the PI CME criteria. This is specifically created for, this is PI CME light, right? So this is only acquiring the data, only a limited, this is much more limited scope than the 32 hours that you would get from a QI or a PI CME activity. So, and so you don't have to worry. I don't think there's any worry about the criteria for this activity. Now, if you're doing a PI activity, it's different, but for this activity, you don't have to worry about it.
Agreed. I think the challenge that we have in our industry is PI and the various acronyms. So the AMA PI activity does have its very rigid process of the stages and when data collection begins. When we're talking about performance improvement, you can consider it as a lowercase performance improvement, lowercase PI, where it's CMS's definition of performance improvement versus the AMA traditional PI CME activity. So I just wanted to reiterate what Tom said, that it isn't that rigorous process. However, if you were creating a capital PI, AMA PI CME activity, that for sure would qualify as a CMS improvement activity.
That's great. And I think that if you look at the numbers that are reported on the ACCME annual report every year, you can see that something like 16,000 people a year do the PI improvement activity. So it's not a huge number of folks that are going through that process. So this is a government mandated process. That's the AMA had bought into this. They were part of the activity group. So this is a government mandated process. So it's a little bit, it's in some respects it's more strenuous and it's less strenuous. So.
I know we don't have a lot of time left, and there's still many questions. So, Tom, I know you put together at Rockpoint a worksheet to assist CME providers on how to actively create improvement activity. As a senior program manager, this is really helpful, to just go through this worksheet and look at the questions and infer your own descriptions, and if you're meeting that. Can you just talk very high level to your worksheet and some of the activities you've been implementing over at Rockpoint and any challenges that you've had?
Sure. So we developed this, it was sort of like, how do we implement this program? So we developed, as you can see, the worksheets up online. How do we do this practically so we keep track of to make sure that we've met all the criteria? So we came up with this worksheet that we use for our activities, and we actually have gone through 2 of them now. And again, it takes understand you're a CME provider. Changing a process is a time-consuming event, right? Changing the processes from where you do your work, it's time-consuming. It's going to take some thought and effort, and so it's not going to be instantaneously. You're just going to start doing this for every activity. You need to start with 1 or 2 activities, get it through your system, figure out all the kinks and bugs, and then you can start doing a lot more activities through it. So we came up with this form. We're more than happy to make it available to whoever wants it. They can email me, or we're actually posting it up to our website. I thought about that this morning. I'm like, why isn't this on our website? So an activity, basically it goes through all the check boxes that are in the 5 criteria, only we created a few, we kind of divided some of them up to make it a little bit easier. So is the activity addresses a quality or safety gap? Is the activity supported by a needs assessment or problem analysis? And then you got to go through what's the need, what's the gap, what's the quality safety gap that we're addressing? Has it measurable aims for improvement? And so you try to list what is your aim? Is your aim for improvement? Is your aim for improvement diagnosing more patients with a rare disease? Is it more finding patients, getting patients quicker to treatment who have migraines, for instance? We're using this for. Is there what are the kind of the pieces that you can use this for? Is the activity activity includes interventions intended to result in improvement? Does it include data collection? How are we getting the data back from the physician? Are we asking them, are you using this survey 2 or 3 times? Are you using this? How many patient engagement encounters have you had over the course of the month? So basically just, again, we'll make it available to people, but it's just kind of gives us a checklist so we can write out a description so that if a physician needs this, or we can send this to a physician afterwards, he has everything he needs to document what he's done. The other piece of the worksheet is what other improvement activities and other kinds of credits can we get at the same time? So can we do MOC Part 2 or Part 4? What are the other improvement activities that maybe this qualifies for? How do we use the electronic medical records or clinical data registry? And does this address a quality measure that's also in the QPP? So maybe they can help, also look at improving quality measures at the same time.
Now, Tom, if you want to send me this worksheet, I can put it up on the CME Palooza website also.
Okay, I'll send it to you in a second.
Okay.
Over. Tom, I want to go back to a few words that really resonated with myself. Changing the process. So how do we as a group make this more known, that these performance improvements can be submitted? Is there a logo? Is the ACCME creating a logo? How is it best to sort of brand these activities and make it more visible in the industry?
So the ACCME has considered making a logo. I think they are actually developing one. So I don't think, and again, if someone from the ACCME is listening, don't get mad at me because I'm not sure. But I remember hearing that somewhere along the line. But I think you can put on the top of your additional, again, you'd have to say additional participation in this CME activity would qualify for as an improvement activity, a MIPS improvement activity. So, but they have to know, the physicians have to know right up front, this is going to be more than just, there's more to this than just sitting and listening to a lecture and filling out a form at the end of the lecture.
All right. Well, we are just about out of time here. And I know that you guys had a few other things you want to go over. And I think that, these are always kind of complex topics to talk through. And I think that we covered a lot of ground here. So for those folks who are watching this live or even watching the recorded version of this, we do have a brief survey at the top of our live tab to get a sense of who's watching and what you think of CME Palooza Fall. So certainly we encourage people to complete that survey. And for those who are watching this and want to view the next session of CME Palooza Live, once this session is over, give us about 30 seconds to refresh our browser, and the next session will be up momentarily. So with that, I want to thank Michelle and Tom and Andy and Amanda for all of their contributions. I think this is probably a new topic to a lot of folks, and I think you guys gave a lot of useful information to folks out there to help them plan hopefully MACRA activities in the future. So thank you once again.
Thank you.
Thank you. Thanks.